Hello, good evening, dear friends, colleagues. It's a pleasure to welcome you to our Wednesday webinar from ESGE. My name is Helmut Messmann. I'm organizing this webinars together with Istvan Ritz. And the reason why I speak before the introduce chair and speakers is as a topic. Today we have really a lot of participants, hundreds, because I want to see my worst complication. This idea came up when we had a similar webinar in the German Society, DGVS, and I realized it's not an honor to be invited as a speaker for complications, and even if you have to talk about your worst complication. Though I was wondering, how can we manage this webinar? And at the end, I thought, well, I invite myself and I invite experts from the executive committee as well. That shows that we have complications, and everybody who does endoscopy has complications. And the most important message is to know more about complications, not only to avoid, but also to know I had made now a complication and I had to manage this complication. And I think I thank you very much that Tomas Hucl from Prague and Marianna Arvanitakis from Brussels will share their complications together with my complication in this webinar. And I'm happy that we have also two super experts for moderating the session with Professor Ioannis Papanikolaou and Katarzyna Pawlak. So first of all, thank you everybody. And now I would ask Ioannis and Kasia to take over the moderation. And I promise all of you stay until the very end. You will see really complications which nobody wants to have again, and especially also my complication was not an easy one. So Kasia and Ioannis, it's your platform now to moderate us. Thank you for joining as well.
So here we are. Thank you very much. Thank you, Helmut. And I'd also like to thank Professor Messmann personally, and also the governing board of ESGE for organizing this great webinar. One of my mentors in my previous years of training used to say that the worst complication in endoscopy is the lack of recognition of the complication, because if you don't recognize it, then it stays there and the consequences can be grave. Whereas if you see it, the timely recognition can lead to better management of the complication. And I think that this is what this session is all about. As previously said, my co-moderator is my dear friend Kasia Pawlak, who is from Poland, and she is the head of the I Committee of the Young Endoscopists of the ESGE, underlining the importance that the ESGE attributes to the training of young endoscopists, not only for the good stuff, but also for other complications. And besides Professor Helmut Messmann, we also have Professor Tomas Hucl from Prague and Professor Marianna Arvanitakis from the Erasmus University of Brussels, who will present complications from the upper GI, the lower GI, and EUS, respectively. So I think that enough said. Tomas will start.
Good evening, and thank especially Helmut for the invitation. My task today is to present to you a severe complication in the upper GI tract that happened to me, and this was a gentleman, a 70-year-old gentleman who was referred to us for resection of a large duodenal polyp. The gentleman had a very rich past medical history, which is important. A significant ischemic heart disease. He was post-myocardial infarction and post-cardiac surgery. He also had a persistent atrial fibrillation, was post-ablation, and had a cardiostimulator placed. And was a diabetic with hypertension, dyslipidemia, chronic renal dysfunction, and monoclonal gammopathy. So he was investigated by his physician for anemia, and a large duodenal adenoma was found. And so he was referred to us for resection. So we can just briefly see it was difficult to image the whole adenoma, the whole polyp in one image. So I'm showing this video. We are in the first part of the descending duodenum above the papilla, and we can see this polyp covering roughly 2/3 at least of the circumference. So we moved to a piecemeal standard resection, a hard resection, and just moved moved onwards, and were able to at the end resect the whole polyp, and from our endoscopic view, we achieved an R0 resection, and the procedure was uneventful since we were aware of the risk of bleeding. We, even though there was no ongoing bleeding at the end of the procedure, we prophylactically applied chemospray on the base of the polyp, and then the patient was admitted to our ward, and the post-procedural course was totally uneventful. So on day one, we draw his blood and noticed LFT elevation. So we performed ultrasound and were able to show that this person also had, apart from other disease, signs of cirrhosis and mild ascites. But since he was in a very good clinical status, the patient was discharged, and he was instructed to contact us in case of any problems. On day 4, the procedure took place on Monday. So on day 4, which was Friday, he noticed black stool at home. However, he was on iron supplementation, but he also noticed hypotension, but didn't take any action. But on day 5, which was Saturday morning, this progressed to a collapse in the morning, and the patient fell down on the ground and hit himself in the head. So his family called an ambulance. An emergency ambulance came for him and picked him up and took him to a local hospital, which was about an hour away from our center. So the question for you, my first question is, what would you do when seeing the patient for the first time? Would you go for a neurological physical examination? Would you do a head CT because he had a hematoma on his left part of the head? Would you just measure his blood pressure and do a blood count, or would you directly proceed to urgent endoscopy? And vote now, please.
These are all relevant questions because the patient had actually had undergone a interventional procedure, but also had his current status was probably affected by the fact that he also had a head injury. So what do you say, Kasia?
Of course, as an endoscopist, but I would not do that. I would not do an urgent gastroscopy because we have our guidelines. However, I will just take a look at the simple measurements. I will check a blood pressure and take a look at the blood count, right? And have like this good interview with the patient, because the other stuff I would perform as a secondary step. So knowing also that he had like humongous polyp removed by Tomas.
Thank you, Kasia. So this is exactly what I think, and also what most of the audience think. So we can, unfortunately, this is not what happened. And the patient was, because of his status that Ioannis mentioned, he was taken to a neurology department of the local hospital, and they performed just physical examination. They investigated, they did measure his blood pressure, which was low. and blood pulse was high. So but they did think that this was not a neurological issue, and they sent this person to an internal medicine department. So these guys did draw blood from him, and they saw a hemoglobin of 75 and also some signs of renal failure. Even though he had ongoing hematemesis and melena in the department there, this was already in the afternoon, they still sent this person for a head CT, which took some time, and the head CT was normal. And in this hospital, endoscopy was not available. And I think we go to the second question. So we are in a small local hospital with this person. Would you do hemodynamic resuscitation of this patient and put him in bed and wait till Monday when endoscopy is available? Would you do a CT angiography? Would you hemodynamically resuscitate with crystalloids and transport him to a tertiary hospital without physician on board, or would you resuscitate him with blood transfusion? His hemoglobin was 75. It's an hour to go to the hospital, to the tertiary center, and transport him with a physician on board.
It reminds me, like, I would say, because I passed European GE part, it reminds me that all answers are correct, but you have to pick up the most relevant one. So, Yanni, now your turn. What you would do?
The hardest question for me. So to tell you the truth, I wouldn't be so calm to have such a patient in a small hospital until Monday. And geography would seem a little bit strange, not exactly the choice, the best choice at that point. So I would transfer him with the physician on board because he had a major. Exactly. Yeah.
Yeah, exactly.
So this is what was not done. And so the patient was taken to our hospital, but without blood transfusion and without physician. So when this guy arrived, and so as I told you, he fell down at home at 10 o'clock in the morning, and now he is now sent to our hospital, and he arrives 10 minutes before 8. He's very weak, lightheaded with dyspnea. We drew his blood. Hemoglobin was 61. We ordered blood, but before anything could be done, this guy had a cardiac arrest, was resuscitated, intubated. However, the resuscitation was unsuccessful, and the patient unfortunately died. There was autopsy performed on this patient. It was a very sad story, and it was found that he had a cardiogenic and hemorrhagic shock as cause of death, but also we found that he had systemic amyloidosis, and many of his organs, including liver, were infiltrated. So GI involvement in AL amyloidosis patient is quite infrequent, but duodenum is actually the most common site of involvement, and patients may present with bleeding. And the cause of bleeding is the infiltration of small vessels that become very fragile, and this is also what was found in our patient. As I already mentioned, we know that delayed bleeding is a most common and very possibly severe complication of duodenal resection. I'm showing a very large study from Augsburg that looked at a very large number, over 100 lesions, duodenal lesions that were resected of various size, either ampullary or non-ampullary. But I would just like to show you this number: delayed bleeding in lesions, non-ampullary lesions larger than 3 centimeters, which is our case, was present in 40% of patients, despite preventive endoscopic measures that were taken after these or during these procedures, similar to what we did. So in conclusion, I have learned a lot. This was a very difficult case, of course, for me. And I already said that delayed bleeding is a very frequent and very maybe severe complications. Back to the Augsburg study, I think there was also some deaths, I think 2 out of the 100 patients. So this can be very severe. Perhaps it's important when we discharge patients to really explain to them that this can happen later. And perhaps sometimes maybe we can observe them later. I think hemodynamic resuscitation is really very important, and even though there is a restrictive strategy of transfusion in patients with a significant heart disease, the hemoglobin, target hemoglobin of 90 grams per liter should be sought, and this was not done in our patient. And I think there's one more thing that I would like to conclude with, and that's what Ioannis said in the beginning, and that is that not recognizing where complication is possibly very risky, and this is what actually happened. So it took too long to recognize what the complication was, and also it may be that someone else is managing our complications, and therefore we need to be very careful, because the others may not manage the complications properly. Thank you for your attention.
Excellent, Tomas. That was an excellent case, especially that we are not dealing like in many cases with healthy young patients, right? We have sometimes like older patients with many concomitant disorders. So as this patient was even diagnosed with liver cirrhosis, so whenever he has like a bleeding, you have to take into consideration, because exacerbation of all these diseases as a consequence of anemia and the bleeding might be just tragic. So thank you so much. That was very interesting, obviously, and we will come back to you later at the end of the discussion. We have some questions, but I think we will push it to the end of our meeting. And now we have Professor Helmut Messmann, and he will talk about his complications. So the floor is yours.
Thomas, if we perform resections in Germany, meanwhile, we do it also for many patients as outpatient, and this can be dangerous. I think it's maybe sometimes helpful to inform the patient a phone number if something happens, where he can contact although gastroenterologists in a private practice say, well, if you have problems, please call this number or go first to the hospital. I'm not sure, was this performed in this case, or what was you in this situation? Was performed.
And as I said, one day earlier, before he went to the hospital, he already had symptoms of bleeding, so he could have called. And of course, he left the hospital with the phone number, and unfortunately, he did not.
Because in this case, my take-home message from your case is, it was a frequent complication, bleeding, as we show in our publication. Almost 40% of these large lesions have a bleeding next day. I think the prevention of late complication is the take-home message, how we can avoid not an immediate, this is later on, how can we also take care of patients who had already left the hospital, is there a chance? And I think this was a very, very important case. What can happen after the resection? Everything went well, but a late complication can also end up in a disaster. Yeah. Okay, maybe I show you now my case, and I share my screen. So then I start with my complication. And as said, it's not easy for presenters talking about serious complication. Yeah, this was a 60-year-old patient. He had a rectal cancer, diagnosed a couple of years ago. You see, staging revealed a T2, T3 cancer with positive lymph nodes in the MRI, and no metastasis. So he received neoadjuvant radiochemotherapy, had a wonderful response, so complete response. Endoscopically, no visible tumor, only the scar. The patient was fit, no comorbidities. And he had another lesion in the cecum, 5 centimeter big lateral spreading tumor, which looked benign, granular type lesion, chained to B to A, histology, tubular adenoma with high-grade dysplasia. This was the initial result before radiochemotherapy, and then after radiochemotherapy, a very nice response. And then we had this lesion in the cecum, a flat lesion, as said, and he was admitted to us to resect this lesion before continuing the treatment in the rectum. Though maybe this was my first mistake. Maybe we shouldn't treat this lesion, but as you see, I performed a piecemeal EMR, not the ESD. I mean, I could also ask you, would you do a ESD? No, I did a piecemeal MR, and this piecemeal MR went quite well. So no problems, despite it wasn't the cecum. I felt comfortable, and the patient, I had to leave the hospital on that day. I remember very well. It was during lunchtime, and I saw this patient in our recovery room, and he had some minor pain, as many patients have after a colonoscopy, because it's bloating or something. Yeah, you had to pressure the abdomen during colonoscopy. And I talked to my colleagues who took over the patient on the ward and listened, take a care on this patient. He had some pain immediately, but I don't think that during the endoscopic resection, I made a perforation. I don't expect a severe bleeding. By the way, why should a bleeding make pain? So at the end, the pain increased in the evening, tenderness of the abdomen, peritonism, the blood pressure, 160, heart rate, 100 per minute. So he looked ill, I would say. Yeah. And I'm sure many of the young endoscopists are now online. Maybe you have this patient. The procedure was performed at 11 o'clock in the morning. Now it's 8 o'clock in the evening. The patient has more and more pain. What would you do now? Yeah, perform an X-ray. Ask your colleague to have a look, another colonoscopy, and maybe there is something went wrong. Just perform an ultrasonography, or go straight ahead for a CT scan, hemoglobin level, or you wait and watch, give some analgesics. Please vote here. You are on call in the hospital. Now you decide what to do. I mean, many patients have after the colonoscopy some pain. So also in this situation, wondering how would you manage? What would you decide?
I would do an X-ray as the quickest way, because sometimes the discussion with radiologists might be difficult.
Okay. Ioannis, what is your selection?
Well, to tell you the truth, I think that the main thing is that you said that we have to choose for just one answer, and that's the hard thing. So the X-ray would be an alternative, but I actually, to tell you the truth, I agree with the majority. I'd go for a CT because of the scale of the procedure. So I'd like to be a little bit more sure.
And what would you expect, or what would you information? What are you looking for now? If
My biggest fear would be perforation, actually.
Perforation.
Yeah.
But I agree with Kasia. We want to also be, as I would say, financial cheap. So even in my unit,
well, we're in Greece.
We went for a simple X-ray, and
we're in Greece, and we don't have
exclude with this simple technique a perforation.
Yeah, exactly.
And now?
Oh, can we see it back? It was so
same question, no perforation.
Yeah.
Would you go now for a colonoscopy? I mean, there is no perforation. Why should not look again?
There was no perforation on X-ray, right?
Huh?
There was no perforation on
There was no perforation. No perforation.
Okay.
Would you now do a colonoscopy? Would you do an ultrasonography, or again the expensive CT scan, or a hemoglobin, or just treating symptoms with analgesics? Maybe we wait until the audience has voted, and then I'm curious, what would you do?
So I know that they rarely can at least you have to have a good ultrasonographist to assess, to me, especially in my circumstances. So you have a good ultrasonographist to assess, like a bowel, just to see if there's not like a symptom after like a wide EMR, just to see if there is no, exactly. I would do CT scan because I want to see if there is any inflammation around the colon.
Majority goes for a CT scan. Ioannis, you choose it in your first selection.
Yeah, so we
you won't believe what we did.
Tell me.
We didn't a CT scan.
Yeah. And
maybe it was wrong. We did a hemoglobin level and the ultrasonography, and we saw abdominal fluid in the cavity and a drop in hemoglobin, but the patient had no hematoschizia.
Okay.
I mean, we can continue now, and now we have 3 answers left, and I think it's now 100% to go for a CT scan.
Go for it.
Nobody should wait and watch if you have a drop in hemoglobin level. Nobody should now do a colonoscopy. It's no hematoschizia. So we did a CT scan, and I hope the majority agrees. I saw in the last question, majority of you did as well. So any idea what you would ask your radiologist what you should look for?
Well, I was in the rehearsal, so my opinion doesn't count. I know the answer.
Okay, then I go ahead. So CT scan. Yeah. So I show you the CT scan, and then you get the message immediately. So hang on. This is a CT scan. It shows a hematoma and the perisplenic, perihepatic, and bilateral in the lower abdomen, and no leakage of the contrast medium. So here was an injury of the spleen with a rupture of the capsule, and therefore intra-abdominal blood. And the patient.
You would never say so.
Sorry?
You would never say so. Like you perform like a wide EMR, colonoscopy went smoothly, right?
Yeah. Let me go ahead. I show you immediately, and then I think the majority will think about, oh my God, maybe I had a spleen injury also in the past, because it's really a rare situation. The patient was immediately operated. It was 2 liters of blood. A splenectomy was not necessary. Interestingly, they could rescue the spleen. In the follow-up, the CCOM lesion was an adenoma with low grade with recent surveillance. The lesion in the rectum was locally treated. The patient did not want to have a TME. So, and was so far good, obviously, with a T1 cancer, and had now a close follow-up. Well, what do we know about spleen injury during colonoscopy? What is a possible mechanism? We think it could be the traction of the ligamentous splenicocolicum by pushing the scope, and then induces a rupture in the parenchyma, which causes a hematoma and then a delayed rupture of the capsule. And this is not an immediate complication. It takes obviously hours. Data, I show you data how frequent. This is data from France, from the French healthcare insurance, sorry. 4 million colonoscopies, perforations 35 in 100,000, bleeding events much higher, but in this not as high, and spleen injuries 2 cases per 100 colonoscopies. And data from Sweden showed also similar. Spleen injury is by far the lowest complication, but it exists 5 complications to 100 in this series. This is a review over a long time, analyzing 100 splenic ruptures during colonoscopy. And you see the majority has pain, 80% within 24 hours. So be careful if a patient has pain. I mean, the majority has pain. But then also anemia is the next symptom. they didn't have any hematologic diseases with splenomegaly. You have, and this was in this patient also, he had a kind of hypertension, cardiovascular instability, and the majority, and this was, we could say, well, in Augsburg, we should go faster for a CT scan if you think about a splenic rupture. So in this case, 70% performed a CT scan. When does this occur? The majority in only diagnostic colonoscopies, no polybectomies or less, yeah, previous abdominal surgery in half of the cases, and intra-abdominal, you see adhesions in 1/3 of these patients. You see splenectomy was necessary in 2/3. Angiographic embolization or conservative treatment is possible, but in our case, we had an operation without splenectomy. Though, what is my take home from my case? You should think more on splenic rupture. And indeed, 1 year later, we had another one because we had made this experience and we made immediately a CT scan. Well, it looks like this patient can have a splenic rupture. So we should be really a bit have more thinking about this complication, which is not as rare as obviously in this data. Think about this complication. The patient has pain. It's the colonoscopy in total was quite difficult. If you know this patient, operations previously can be a problem, and also inform your patient in advance about complication. I published this patient consent form in Germany, and we have now also included organ injury like splenic rupture, even if it's very rare, but this was my take home, and also teach your colleagues about this complication, speak about the complication, and it's for sure the most important thing is to recognize a complication. In this situation, it took a time, it took a while. Maybe we lost some time because we did not first the CT scan, but if you do now in every patient after a colonoscopy CT scan, we have thousands of unnecessary CT scans. So the clinical situation plays an important role, and you should inform this patient if you do it in an outpatient manner, which is in the majority of cases unnecessary. Yeah, and I stop here with my invitation in a couple of weeks to sunny Barcelona, and I'm happy if you join this winter, Christmas time. It's a long time, but save the date in December for Augsburg is our 20th endo update in Augsburg with international guests like Yahagi and Oyama. That's my presentation, and I'm happy to take now or later questions, whatever you decide, Kasia.
Great.
And,
I was intrigued by one question that was made that said, during the surveillance colonoscopy, did you do anything different, having known that, having known of this complication? Did you alter your technique in the colonoscopy, push a little bit less, for example? And I would like to generalize this for your general practice in colonoscopy. How should we do it?
I think my recommendation is, if possible, the doctor, that's me, who did this complication, should also do the next surveillance colonoscopy. If the patient accepts, sometimes the patient said, no, Dr. Messmann, you did a severe complication, but then you should inform your colleague. I mean, it's in the report that there happened a severe complication, and you will explain the patient, and you stop maybe earlier if you feel that this is for adhesions or whatever is so difficult, and then stop the procedure and think about other possibilities, maybe colonoscopy with X-ray or whatever. But we didn't have any severe complication, or at least the colonoscopy was not as difficult as we expected in the follow-up.
Also, I would like to make a point, like, I love your informed consent, because this is what we miss in a very many centers. Like, we are missing a good informed consent to explain, and are missing the time of explanation to the patient, like what can happen, what eventually can have a consequences of this complication. Because in most of cases, patients are not so super aware of this, that we are doing knee surgery, and even like diagnostic colonoscopy can cause problems sometimes, very rarely, but still. So I love the good informed consent, and this is what we also supposed to make, and also spend some time with our patients, because even if this will happen, then they know, and they know what can be next. They are not so scared, right? So
okay,
good.
so then
We will continue like with the questions at the end, because there's a lot of questions actually to you and to Thomas. So, Yanni.
Okay, so let's move on to our last case. We have Marianna Arvanitakis, who will present her case regarding EUS. Marianna, the floor is yours.
Thank you very much. And I also want to thank Helmut for this invitation, because I think it's extremely important to be able to analyze these adverse events, to understand what happened and try to avoid them and prevent them. And my complication, not always it finishes, of course, in a very dramatic way, but also it's important to know that this can happen again. So even if we try to prevent, it doesn't mean that it's statistics that happen once, it won't happen again. So we know that statistics are lies, and we have to be ready to have this happen again. So this is my case, a 60-year-old gentleman who was diagnosed in about a year before the procedure took place with locally advanced adenocarcinoma with vascular encasement. So he had the indication, of course, of neoadjuvant chemotherapy and not upfront surgery. He had jaundice because the mass was in the head. He had the metal stent. And he continued his chemo for some months. So this brought us 9 months afterwards, in November 21, where evaluation showed that he could be resecable. So he was taken for surgical exploration to proceed to a Whipple procedure, but unfortunately the mass seemed not to be resecable, and he had at that time a cholecystectomy. And the patient presented with postoperative pain and also development of ascites, as you can see in the CT scan here. This was done some days after the surgery. And they also had elevated CRP. And when they did the puncture of the ascites, it had this serous aspect with low triglycerides but high lipase. So it was considered to be maybe like a peroperative pancreatic rupture. And a pancreatic drain was put in place at that time. So this was, he stayed in the hospital all this time, and he had a CT scan for follow-up. And we see that this, he still has ascites, but there is an organization of a collection, which is compressing the stomach. He had multiple episodes of fever and the positive blood cultures with digestive germs of gram-negative bacillus. The percutaneous drain did not seem to be in this collection, and he was put on antibiotics. He was discussed, this patient, in the MDT, and because they wanted to start chemo again, they wanted us to drain this collection. So he was scheduled for US guided drainage. So he was on his, he had antibiotics. We did standard cystogastrostomy first with a cystotome. You can see that we have the guide wire inside the large collection, a 10 French cystotome. And the first stent that I put in place was migrated inside the collection, as you can see here. So I dilated the tract on the guide wire that was still in place, because I had put 2 guide wires in place. I did some manipulations to try to go with a snare to retrieve the stent, but I quickly stopped doing that because, of course, it's very difficult to go into a tract that's not organized yet. So I decided to stop manipulations and provide adequate drainage. I put 3 stents to drain the collection, and I didn't manage, of course, to retrieve the migrated stent that you can still see in the image. So after the procedure, this procedure was under general anesthesia, he had intubation, so he was in the recovery room. He was extubated, but he had hypotension, hypoxemia. He had to be re-intubated, and he was transferred to the ICU. And the day after, he was in severe septic shock. He was not responding to our noradrenaline, and the patient unfortunately passed away 24 hours after the procedure. So I thought a lot about this case. It was not the 15th it was the 25th of December. So it was Christmas, and it was very difficult to talk with the family that was in the ICU for this patient that had a really long difficult outcome with 6 months of chemo and surgery, very fragile patient. I was thinking maybe that this was not a real pancreatic collection. It was not retroperitoneal. It was collected ascites, no, maybe not with a real wall. So maybe a wrong indication. Maybe that the fact that I tried to retrieve the migrated stent maybe was related to maybe a false root and some peritoneal leakage. So we didn't do autopsy, of course, but all these questions remained unanswered. So I had another patient. This was some months afterwards. This patient was a more clear-cut 53-year-old man, alcoholic pancreatitis, acidocyst, and had the persistent pain after the bout of alcoholic pancreatitis. And you see that he has a very nicely formed acidocyst with a wall. So he had pain, so it was scheduled for US-guided drainage. I, again, did the classical cystogastroscopy with a cystotome, 10 for cystome, put 2 guiders, and still managed to migrate the first pigtail stent inside the collection, but also had some bleeding at the puncture site, despite the fact that he had previous cross-sectional imaging showing that there was no pseudoaneurysm. So at this point, what would you do now? You have a guide wire in place, a second guide wire, you'll try to dilate, do a large balloon dilation and try to access the cavity to get out the migrated pigtail, or you just assure drainage of the collection, refrain from other manipulations?
Not an easy choice. I was thinking about that in the first case, but Yanni, you are the I would say more experienced.
Yeah, sure, but you're younger. Well, I think this is really hard to answer. As in the previous case you showed, I mean, once you start being interventional and trying to do things to prevent, fix your what went wrong, then every step you take takes you deeper and deeper. So sometimes it's wiser to just assure drainage of the collection and refrain from other manipulations. Maybe I would do that.
Yeah, I think that you have got a point there, Ioannis, as about 76% of our audience. And also, I'll show you why. Because you do get deeper and deeper. So I did not want to take any other risks for this patient. So I had the second guide wire. I've used the cystotome to put a second guide wire inside through the first guide wire. And I put 2 pigtails to be sure that the patient is correctly drained. The bleeding stopped. It seemed to be like venous bleeding from the wall. But still, it did impede a bit the visualization and everything. So it was an additional reason not to go any further that time. And we did a CT scan just afterwards to be sure that there's no pseudoaneurysm. There was not, and there was no active bleeding. The migrated stent was still in the cavity. It didn't go away, unfortunately. And the two additional stents were draining well the pseudocyst that was starting to decrease in size. So at this point, I know that I could reschedule the patient some days later to be sure that the tract was already a bit organized, a bit mature. We could dilate and then try to get into the cavity. But I wouldn't do this, of course, with a freshly created fistula. But here I was a bit traumatized by this. So what I did is I asked for help. And I asked Jacques Devière, who was the head of the department, say that, look, I have this complication. I was traumatized by a patient that I lost. I want to do this with you just to be sure. And he said, of course. So he was rescheduled some days later. You can see that the pigtail is still there and the two pigtails are drained. So he got access, and then he did a large balloon dilation, a 12-millimeter balloon dilation. And then there was bleeding, a lot of bleeding. He couldn't see anything anymore. So at that point, he just put a lamps to get a bit of coaxial tamponade on the bleeding site. It was, again, bleeding that seemed to be from the wall. And this was the lamps was put next to the pigtail that was still in place. And he refrained from doing any other manipulation at that time. So that's why I tell you that sometimes things can get worse. The patient went well. It didn't have any hemodynamic complications. It was really bleeding from the wall, but enough to prevent you by having a good visualization. And then he was rescheduled finally some days later. The lamps was taken out. The pigtail was also taken out after putting an axial scope, a gastroscope inside in the cavity. Now the cavity was the tract was well organized, and we can go inside with the scope, take out the stent with a forceps or ratus forceps, and then take out the lamps completely and leave only a double pigtail stent inside. So the patient went well. The pseudocyst was completely regressed. And this is one of the review articles that I found, where my friend Jimil Shah is co-author as well from India, where they show that complications are not rare, and improper deployment, which also includes internal migration, can reach 2 to 8%. So the tricks that I have put in place to really avoid this is to have a very good visualization of the stent with X-ray, and also during the deployment, which is not easy. When you put the stent inside, you have a lot of liquid coming out, so not always easy to have this. So you have to really keep an eye on the corner where you have the blue stent coming in, and try to aspirate a bit the liquid. There are stents with radio-opaque markers that can help you as well, having an internal and external radio-opaque marker. And we also add a marker for this. There's no radio-opaque marker. We add them with a standard black marker to really see the black part coming in that shows you the second pigtail, so you don't push in too hard. You push in slowly and gradually, taking into consideration the length of your stent. If it's a short stent, of course, you have to consider it before starting to deploy. I always have a second guide wire when I'm putting pigtail stents, because I always want to put 2 stents just to be sure. And that second guide wire can guarantee access if something goes wrong, as in these 2 cases. When you're at the end, and when you know that you have seen your marker and you're ready to deploy the pigtail, at that case, we will bring back the guide wire to release the internal pigtail, and you will torque the endoscope in another axis and push the stent out with the pusher. And at that point, if the pigtail is released, it's not rigid anymore. You're not in the axis that pushes inside the cavity. You're in another axis, and probably hopefully the pigtail will go on the side and will not go into the cavity. And if you have it migrated inside, you have to wait for tract maturation, but not too long, because you still want to have a cavity that's left. So you should take the patient in about a week or so, but not like 1 month later. So what did I learn? So apply all preventive methods, as I said. I would not advise to try to regain access during the index procedure, because it's a tract that's not yet mature, and you might risk having a false tract. you should inform the patient and explain the next steps, and don't be scared or embarrassed to ask for help, because there's nothing that makes you feel more humble than a complication like that, where you have a dramatic outcome for the patients. So thank you very much, and I'm happy to discuss about this.
So thank you, Marianna. And I'd like to say that one of these points, these final points that you stated and you highlighted, was also very nicely accepted and acknowledged by our viewers, the colleagues watching the webinar. I think that the point where you said that seek for help when if you need it, and I think that this is very nice. I think that there is no room for false egos in endoscopy, especially if patients, the health of our patient is at stake here. So I'd like to double congratulate you, not only for the excellent presentation, but also for the wise clinical decisions that you demonstrated. So Kasia.
Yeah, I think we can go to the questions, but I would like, I think there is a lot of questions to Tomas and to Helmut, so let's give people time to prepare questions to Marianna. And I have questions to Marianna now. So Marianna, do you think that it would be reasonable to do in this situation, whenever you have a stent migration, to perform to all patients a CT scan just to see if there is any vessels which can be injured, like by the left stent? Do you think it's reasonable to do that for all these patients?
Yes, we usually always have a CT scan to detect any pseudoaneurysms. So now, if you have done a CT scan before and you don't have a pseudoaneurysm and you get just you had a migration, there was no bleeding like the patient that I showed, the second patient, I think it's reasonable. You don't have to do another cross-sectional imaging if the patient is okay and you're going to schedule them anyway. But if we relied maybe on previous examinations that were like some weeks earlier, and you don't have a fresh examination afterwards, maybe I will do a cross-sectional imaging just to be sure of how things are in the collection, and to be sure before you schedule them again.
Excellent.
How fresh would you like the examination to be, Marianna, before you start you do the procedure? How fresh would you want your last cross-sectional imaging to be?
But usually we try to have a like less than 2 weeks cross-sectional imaging. If we have a CT scan that dates from 1 month, then we really want to be sure that still is a collection to drain. That's the first thing. So we probably want to do also one before we do the procedure. So this is another reason why we like to have fresh cross-sectional imaging.
Tomas wants to comment on that.
Just wanted to ask Marianna, did you do a CT scan post-procedure in your first case?
Yes,
yes. Progressed and had a septic shock. Do we know what happened there? Was it?
So yes, he had a CT scan. So there was, but it was difficult to see if there was an additional leakage or something. It will be difficult to see because he had the ascites already. He didn't have any signs of perforation. He didn't have any pneumoperitoneum. He had the stent inside the collection. Then he had the 3 stents draining outside. He didn't have any ischemia or anything else, additional extra procedural complications that also can occur. So it could have been even like sepsis because of translocation, massive translocation in a patient that's very fragile, and maybe a collection. I still believe that this was not a clear pancreatic collection. It could have had maybe a wall that was not very well organized because it was not like a pseudocyst or a WAN. So it was something atypical.
Yeah.
Okay, let's move forward. We have a few more minutes, so maybe more questions. This is a good question from Susanna. If there is any guideline on how long patients should be observed after specific interventional procedure? I don't think so. I didn't meet ones. Like, do you? Did you find some specific guidelines on how long patients should be observed after procedures? No.
That's a good question, but I am not aware of any either. And
I think this is our own experience, like the center experience, and based on that, we are holding patients for some time.
Yeah, we have in Germany some recommendations regarding the sedation guideline, how long they should be monitored, and yeah, but I think we don't have guidelines to say, well, if you perform a polybectomy, how long this patient should be monitored in the clinic.
I think what's also interesting is that there are major differences between departments, and some will just discharge the same day or the next day, and some will keep the patients for 4 days. And maybe we could, see if there's differences in the rate of complications.
I think the decision is made during the procedure and your experience. If you have a difficult procedure, you feel as an expert or as an endoscopist not happy with the procedure, how it worked, and take care of this patient to know, well, there might be some a higher complication. If it's a nice procedure without any complication, the patient feels immediately good. There is no need to have him in the hospital for 1 day. Yeah, so it depends really on the local situation, on the patient's comorbidities, whatever. I would be careful to write here a guideline, because then, yeah, it's almost impossible. It's very individual.
It probably wouldn't apply for every case, because, for example, trying to take some messages, for example, from Thomas's case, if this patient was somewhere more centrally, closer to the department, to your department, Thomas, I think that maybe the management would have been better, and maybe this patient could be saved. This only it gives me the thought, what would happen if this person coming from a country with many islands, for example, if we had someone who was from some small island of Greece, I would be very reluctant to send him to a small island. I would keep him in the department. Whereas if he stayed somewhere close to the hospital, then I would be more calm to send him home, for example.
Okay, I think 2 last questions, and then we will go to the slides, Yanni. So one question is for Helmut, and one question is for Tomas. So question for Helmut for Tomas. So this is about your case, Tomas. So somebody's asking, what was the learning point in this case for the team, because the patient was cirrhotic. So what was the child put score, and what if the indication was appropriate?
So when the patient was indicated, we did not know he had he had cirrhosis, and I think this is, I guess, a learning point. And someone suggested, I guess you suggested it when discussing right after my case, patients, we need to be aware of comorbidities. But in this case, actually, there were comorbidities we did not know about, and it was the cirrhosis at the time we did the procedure, and also the amyloidosis, which probably contributed to the risk of bleeding. So we do treat patients who are ill, and they may even have more disease that we are aware of. They would, I guess, I would take this as a learning point here.
Yeah, exactly. And one for Helmut, actually too. So the question was, because there was a splenic rupture, so if the colonoscopy was difficult to you when you were performing the procedures, if you felt that there is any looping, and if there are any other preventive measure for post-polypectomy bleeding, if you would have choose any.
Yeah, I remember this colonoscopy very, very well. It was a difficult one. I was struggling, yeah, and this should be also an advice or a point which you should think about when you stop the procedure. The patient feels not good, he has pain, and if it was difficult and you had some looping, then the risk for some injury like spleen for sure is probable. Bleeding prevention, I mean, here we have good data. Bleeding prevention is nowadays, I mean, this case was in 2019. Usually we did at that time not usually perform any prophylactic closure, which is one option in the right colon, or some powder or hemostatic gels. So we have now data that clipping in the colon ascending or in the duodenum, Tomas showed that duodenal bleeding is also very severe. We should perhaps, at least in this part of the GI tract, do prophylactic, but it does not always work, as shown in our data in the duodenum adenoma. But also, yeah. And this patient I showed, he had no bleeding, despite he was a large resection. Bleeding was not the problem. The spleen was the problem.
Excellent.
So, time to wrap up. I think that this session, this webinar was so nice. It has been illustrated by the participants, the big number of participants. We are now at, we were 235 now. Previously, we were even more. Also, the comments are very encouraging, and also they it was suggested that maybe we could repeat a webinar like this on a regular basis.
I was thinking about this idea. I mean, we have 3 other guys in the executive committee who could be the next, like our president, the incoming president, and the past president, which is Ioannis, Cesare Hassan, and Ralph Bishops. And I'm sure they are happy to present their most worst case complications.
Yeah.
So,
and at least routinely, as Marianna proposed, every year in Halloween.
Yep. We have the whole governing board to present complications.
And then we asked the governing board. Now the executive committee was the first to show how that we have complications, and everybody, we should talk about complications. I think this is a message to all of us. Yeah. Don't try to hide your complication.
Exactly. Thank you for the idea, Helmut. And I'd also like to thank Marianna and Tomas for participating. I'd also like to thank all of you who participated in this webinar. Thank you very much for attending. I'd like to strongly suggest that you participate also in the upcoming ESGE days in beautiful Barcelona. I think that there we can have the opportunity to discuss issues like this all together from close during the sessions, during the breaks. I think it's a congress that's growing, and it's really worth attending. So that would be our first message. The second message is to take advantage of the ESGE Academy. This is our new platform. This is an educational platform that links guidelines, links cases, links the previous videos from previous ESGE days. I think this is one of the major benefits for the members of the ESGE, and I would strongly suggest that we take advantage of it, all of us. The next slide is a colorful slide that we developed in close cooperation, the I group, the young endoscopists, with Kasia leading it. We also helped from the membership working group as well. So it underlines the benefits and the opportunities for young endoscopists to be members of the ESGE, not only in terms of training, not only in participating in seeing all these webinars, but also in being members of this big family, this big growing family of endoscopists throughout Europe and the ESGE in general. And finally, I'd like to thank the ESGE Governing Board for making these webinars possible. Once again, Helmut, thank you for the idea, for the initial idea. And last but not least, I would like to thank the webinar team, especially David Inker and Vaso Prifti, for all their assistance and making this nice webinar possible. Thank you very much, and good night, everyone.
Good night.
See you soon.